بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله وعلى آله وصحبه وسلم أجمعين. اللهم انفعني بما علمتني وعلمني بما ينفعني وزدني علما إنك أنت العليم الحكيم. My topic today is about the adrenal mass lesion, the common causes, less common causes, and the clues to differential diagnosis. Essential information for adrenal mass lesion. Primary diagnostic consideration, particularly in oncologic patient population, differentiate adrenal metastasis and incidental adrenal adenoma. Imaging intensive approach advocated by specialty societies to confirm adenomas, though vast majority of adrenal incidental lesions are statistically adenomas. Combination of imaging, CT and MRI, and clinical history usually allows confident diagnosis. CT and MRI protocols geared towards identifying intracytoplasmic lipid in adenomas. Lipid-poor adenomas may be problematic, though washout kinetic clinical history help in diagnosis. Malignancy and extra-adrenal finding additional metastases aid the diagnosis. Cushing syndrome excesses cortisol 75 to 80% due to primary pituitary adenoma secreting excess ACTH. Cohen syndrome excess aldosterone 75 to 80% due to adrenal adenoma and usually small. Addison disease, adrenal insufficiency due to autoimmune disease, 80% in Western countries, bilateral metastasis, adrenal hemorrhage, or systemic infection are some of the differential. Clinical history of hypertension may suggest pheochromocytoma, but biochemical workup urine metanephrines confirm the diagnosis. The common causes for adrenal mass lesion is adrenal adenoma, metastasis, adrenal hemorrhage, pheochromocytoma, adrenal cyst, and retroperitoneal varices or vessels can mimic mass lesion in the adrenal gland. Clues for common diagnosis: adrenal adenoma. It is a well circumscribed, rounded or oval homogeneous low-density mass lesion on non-contrast CT scan. If it is less than 10 Hounsfield unit, highly specific for lipid-rich adenoma. Histology of lipid-rich adenomas characterized by intravoxel signal drop out at outphase T1 weighted images. Lipid-poor adenoma are best diagnosed on CT scan with an enhanced, and 15-minute delayed imaging to calculate the washout. Absolute washout should be more than 60% and relative washout should be more than 40%. Rare false positives, hepatocellular carcinoma, renal cell carcinoma metastasis, pheochromocytoma. Web-based calculators readily available for calculation of the washout, absolute and relative washout. Here, non-contrast CT scan in patient 45 years old shows incidental mass lesion about 2 cm, low attenuation about 0 H Hounsfield unit in the left side, and this is characteristic for livid rich adenoma and no need for further evaluation. Here there is an adrenal mass lesion on the left side, incidentally discovered with attenuation values measures about 32 HU, and the washout, absolute washout, it is more than 60% confirm the livid ball adenoma. Here there is a mass lesion on the left side on the T1 weighted images. Intermediate signal intensity, and in the out phase the same mass lesion shows a drop in its signal intensity, and it is characteristic of feature of livid rich adenoma, and no further evaluation is advised. Here there is ultrasound mass lesion in the right adrenal gland on the transverse section and sagittal section in 70 years old woman with increased liver function, incidentally discovered mass lesion. And the ultrasound, the appearance is not non-specific, but on the CT scan confirmed it is the density of the mass lesion is less than 10 Hounsfield unit, and it is confirmed livid rich adenoma. Metastasis and lymphoma to the adrenal gland. Metastasis primary sites include lung, breast, kidney, melanoma. Cannot always be distinguished from livid ball adenoma by imaging alone. Clinical history, comparison to the prior studies, identification of additional extra-adrenal disease is the diagnosis. PET CT scan, useful in oncology patient, may help to identify FDG, avid adrenal metastasis. Lymphoma, non-Hodgkin lymphoma most common, present as rounded or triangular in shape, mild enhancement, FDG, avid on PET CT scan. Here there is ultrasound mass lesion, mass in the region of the adrenal gland in this patient with lung carcinoma. Dedicated adrenal CT scan showed the prolonged absolute washout kinetic less than 60% and confirmed the metastasis. Here, this is PET CT scan of patient with increased metabolic hyperactivity on the right adrenal gland. It is more than the liver and consistent with metastasis. Here, this is another patient with left adrenal mass lesion with lung cancer and metastasis. It is confirmed at adrenalectomy for this patient. And a washout for this patient suggest livid ball adenoma, but on the surgery histopathology confirmed it is adrenal metastasis. Here, this another patient with back pain, lethargy with lung cancer. We see bilateral mass lesion, shows large necrotic area with consistent with metastasis. Here another patient with bilateral adrenal mass lesion. The same patient with heterogeneous enhancement with extension to the left kidney, and this patient proved to be adrenal lymphoma, and the patient given treatment for lymphoma. Adrenal hemorrhage, adrenal acute can be a chronic. Acute hemorrhage, homogeneous around non-enhanced hyperdense mass with a density measuring about 50 to 90 HU. In the chronic cases, mass with hypoattenuating center looks like pseudocyst, sometimes with calcification. Unilateral can be unilateral, usually due to direct trauma or iatrogenic liver transplantation, or can be bilateral response to shock, post-partum and severe burns and sepsis. Here, this patient with a right adrenal mass lesion, in contrast, enhanced CT scan post-trauma shows right adrenal hematoma. Here, another patient with non-contrast enhanced CT scan, hypotensive patient with metastatic lung cancer, shows bilateral adrenal masses, bilateral adrenal hematomas, and the right one is larger with bleeding. These adrenal metastases with bleeding. Pheochromocytoma will circumscribed rounded mass lesion measuring about 3 to 5 centimeter. Pheochromocytoma that occur as part of syndrome may be detected as small asymptomatic mass. Syndromes associated with pheochromocytoma, multiple endocrine neoplasm like type 2 and type 3 neurofibromatosis, von Hippel-Lindau-Carney syndrome, and tuberous sclerosis. Hyperintense on T2 weighted image with heterogeneous bright enhancement, a plus-minus hemorrhage, necrosis, and calcification. Supporting history, hypertension, palpitation, headache, and biochemical data, urine metanephrines confirm the diagnosis. Here, patient with MEN2A syndrome with increased urinary metanephrines with this T2 weighted images with bilateral adrenal mass, and this is hereditary pheochromocytoma. Here, another patient with contrast enhanced CT scan, 26 years old, with marked enhanced mass lesion in the right adrenal gland, measuring about 4 centimeters. This is confirmed pheochromocytoma. The same patient with T2 weighted images on the mouth light bulb appearance and hyperintensities, characteristic feature of Pheochromocytoma. Another patient with right adrenal mass enhancing with Pheochromocytoma with right renal cyst adjacent to right renal cyst. Here there is a mass lesion in the right adrenal gland, and this is a MIB CT SPECT examination. Was performed to exclude metastases and shows hypermetabolic mass. It is a Pheochromocytoma. Patient presented with headache, hypertension, palpitation, and sweating. Adrenal cyst, well-defined, non-enhancing water density mass plus minus calcification, looks like eggshell calcification. Thin wall septi calcification favors cyst rather than livid rich adenoma at non-contrast enhanced CT scan. Rarely large lesion plus minus internal hemorrhage. Here you see adrenal mass lesion on the right side, hypodense, consistent with right adrenal cyst. Differentiating from adenomas may be difficult, but septation and thin calcification favors of cyst. Here, this is another patient with ultrasound. This is a right adrenal mass lesion with acoustic enhancement and calcification consistent with cyst. Retroperitoneal varices or vessels may be tortuous, like splenic artery and varices, and seen in the suprarenal space, giving the appearance or simulating the adrenal mass lesion. Contrast enhanced CT or MRI or Doppler ultrasound usually establish the diagnosis. Less common causes: adrenal myelolipoma, adrenal TB and fungal infection, adrenal carcinoma, renal cell carcinoma, gastric diverticulum are mimicals to the adrenal masses, adrenal hyperplasia, and adrenal ganglioma. Clues for less common causes: adrenal myelolipoma, it is uncommon, non-functioning benign tumor of the adrenal gland. Macroscopic fat interspersed with soft tissue myeloid elements. Can present with hemorrhage at non-contrast enhanced CT scan. Coronary reconstruction may helpful to determine organ of origin. Adrenal myelolipoma versus exophytic renal angiomyelolipoma. It is present hyperintense on T1 weighted images and focal area of loss on fat suppression technique. Interface between fat and soft tissue elements will lose signal on opposed phased gradient sequences. Echogenic mass at ultrasound may be indistinguishable from surrounding retroperitoneal fat until mass effect seen. CT and MRI are diagnostic in most cases. No treatment needed in most cases, though large myelolipoma may emerge. Resection advocate for large asymptomatic or atypical lesion. Here contrast-enhanced CT scan of fat attenuation. On the right, adrenal mass lesion measuring about -30 Hounsfield unit, and it is pathognomonic with myelolipoma. If it is large, sometimes it is difficult to differentiate from liposarcoma or renal angiomatosis and need further coronal or sagittal reconstructed images. Here, this is axial contrast-enhanced CT scan, mass lesion in the right adrenal gland with the macroscopic fat and soft tissue component typical of myelolipoma. Adrenal TB and fungal infection. It is heterogeneous, boldly enhanced mass lesion or masses during the acute infection. If it acute, mild to marked enhancement of the adrenal glands with a preserved contour. In a chronic stage, small calcified adrenal glands. Adrenal TB, most common cause of Addison syndrome or adrenal insufficiency in third world countries. Here, patient with non-contrast CT scan with bilateral calcification of adrenal gland due to granulomatous disease. And this just adrenal TB. And patient presented with adrenal insufficiency. Adrenal carcinoma present non-functioning tumor mass larger than 10 cm at the presentation. Functioning tumor may be smaller and it is appear less than 5 cm. Early invasion of the IVC accounts for poor prognosis. The mass can show necrosis or hemorrhage or calcification in 30%. Here you see mass lesion in the right adrenal gland with soft tissue and necrotic components, and with invasion of the adjacent tissue suggestive of the adrenal carcinoma. Here, this is another large mass lesion with heterogeneous enhancement and necrosis, with invasion of the left renal vein and extension to the IVC, and inseparable from the left kidney, and this mass, it is left adrenal carcinoma. Here, another invasive mass lesion in the region of the left adrenal gland with calcification and invasion of the splenic vessels. Here, there is a large white mass lesion with calcification and necrosis and heterogeneous enhancement on the right side. Renal mimics of the adrenal mass is large kidney tumor. Large tumor arising from the upper pole kidney sometimes may simulate adrenal carcinoma. So we should look for clear sign, defect of the renal cortex at the origin of the mass. Coronal CT reconstruction or MRI helpful to determine the organ of origin. Sometimes gastric diverticulum can mimic mass lesion in the adrenal gland. It appears as rounded in the suprarenal side and may contain fluid or gas. Contrast material given extra oral contrast or gas granules place patient in a prone position to make the diagnosis. Adrenal hyperplasia may appear normal or normal shape but increase in thickness more than 10 mm or may be nodular hyperplasia. Nodular hyperplasia can be difficult to distinguish from small adrenal adenoma or other lesion like metastases. Hyperplasia or swelling may occur in response to stress. Pituitary ACTH secreting tumor accounts for about 75 to 80% of Cushing syndrome cases. Congenital adrenal hyperplasia or ectopic source of ACTH. Here, patient with bilateral adrenal masses in patient with Cushing syndrome, suppressed ACTH and abnormal dexamethasone suppression shows nodular adrenal glands. And this ACTH independent macronodular hyperplasia confirmed at the resection. Here, this patient with contrast-enhanced CT scan, we see bilateral large masses, larger on the left side, and this is characteristic of congenital adrenal hyperplasia. And this is autosomal recessive disease, usually due to 21 hydroxylase deficiency, and diagnosed in the neonatal period and is responsible for most of the adrenogenital syndromes. Rare but important causes: adrenal collagen tumor and adrenal hemangioma. Clues for less common rare causes: adrenal collagen tumor, means coexistence of two contiguous but histologically distinct tumors within the same adrenal gland. Can be adenoma with myelolipoma or adenoma with metastasis, most common combination. Here we see patient with hypervascular mass, metastatic melanoma within a larger homogeneous low density mass lesion of adrenal hematoma. So this is metastasis with adrenal hematoma, and this is a collagen lesion. Adrenal hemangioma, more than 10 centimeters, central low attenuation, necrosis or fibrosis plus minus calcification. Alternative differential diagnostic approach: bilateral adrenal masses, metastasis, hyperplasia, lymphoma, hemorrhage, TB, or fungal infection, pheochromocytoma about 10%, adenoma about 10%, or combination of two of masses, adenoma on one side, myelolipoma on the another side. Thank you very much for listening, hoping you are benefit from this talk, and see you soon in another talk.